Now, in our hospital in Surgeries, we have a supported harness treadmill system for gait training, where the patient is suspended on the harness. It takes almost 80 to 90, even 100% of the load of the patient, and on the treadmill, a manual ambulation or gait training is given to the patient. So this gives the patient a sense of verticality, gives them the weight bearing as per tolerance. So let's say 0% weight, 20%, 40%, 50%. And now we are actually looking forward for the robotic assisted mobility or rehabilitation, where we are looking forward now for the exoskeleton, which can help the patient to ambulate. And this is a very good, in India, I know 3 or 4 centers only which are currently using this, and I think this is soon going to change. Again, this is the future. Artificial intelligence is being used. I'm very sure all of you are very aware that in Surgeries we have launched the Ortho AI, which is used now for predictive analysis of patients for orthopedic cases, and very soon we are in the process of launching our Rehab AI also. So this will help in predictive analysis of recovery outcomes depending on the patient's condition and problems. What should be the essential feedback methods, treatment options, that is also decided. So I think this is the future. So it's frequently said that artificial intelligence will not replace the healthcare providers, but healthcare providers who are well versed with artificial intelligence will definitely replace other healthcare providers. So this is something that all of us should definitely be aware about. Another factor that we have using are VR and augmented reality. Again, we have a non-immersive virtual reality trainer with us that we are using. We are currently using this for patients with stroke and patients with spinal cord injuries. And this is something very important. They are able to go into a virtual world and perform tasks or movements which normally they would not be in a position to do. आप कितना भी externally उनको stimulate करो तो will not do it, but this becomes a very good thing. AR, augmented reality, we have not yet started using, but augmented reality actually gives them the real world situation. So you can actually create your roads, you can actually create your hospital environment or your home environment and teach them in that particular component. So these are the trends that are going ahead, and they are now started being adopted in our future, in our professional domains. In fact, I'm very pleased to inform that we have our upcoming conference in November, where the theme of the conference is on artificial intelligence and technology in physiotherapy rehabilitation. So the entire process is only directed towards the latest trends. So as I said, there are tools that are being used. In fact, now we have in physiotherapy, we are also using wearable technology. So patients have monitors. This is also in market, it is used, and fortunately it's not very expensive. So wearable devices are being used which can monitor the patient's real-time movements, help us give predictive movements to the patient, what should be your position, what should be, where are you going wrong. Real-time biofeedback is given to the patient, and along with it, even tele-rehabilitation. Of course, tele-rehab is not new, we all are very aware of it, but even this is used for taking care of the patients with back problems. And finally, coming to electrotherapeutic domain. Electrotherapy is used very frequently in physiotherapy for pain management. So most of us are already aware of using interferential therapy and transcutaneous stimulations or so. What we are using, these two domains we are already having with us. One is functional electrical stimulation. This is we are using for our patients for training of movements, especially for spinal cord injuries. And we also have the NMES, neuro electrical muscle stimulation, for training the patients for their muscle paralysis and movement. So these are the new things that we are using currently. For pain management, these are new in the market, but we have not started utilizing it per se in our clinical practice, because there is a very gray area. The literature for spine is not published for both, for high intensity laser as well as for extracorporeal shockwave therapy. Extracorporeal shockwave therapy is like ultrasound, the US that we have ultrasound therapy, but it's a burst of sound wave given at a very high frequency dosage, which helps in tissue healing. But as I said, the literature for spine is very grey, and that's the reason why we don't venture into it. And finally, of course, when we are taking care of the physiotherapy, lifestyle management, that is including physical activity, regular tasks, irrespective of back pain, no back pain. Just today when we were discussing the case, we were talking to the client about importance of forward and backward walking. We give exercises of forward walking to the patient, but backward walking as a simple movement is also very important for strengthening our spinal muscles as well as the gluteal muscles. So we are very aware that your gluteal muscles and spinal muscles are interconnected as far as a functional unit is concerned. Diet and nutrition to the patient. So we have our team members who talk about the good amount of diet and nutritional factors. And finally, sleep and stress management. So all of these constitute equally, although they are not directly in the purview of physiotherapy, but they are also very important for management of patients. So finally we come to the components of coping strategies and psychological support, because when patients are suffering, they are going through a particular problem for a period of time, having a good amount of psychological counseling and support system is important from all of us. And I think events or conferences or trainings like this would help us understand each other's perspectives better and help get the healthcare outcome better. So finally, key takeaway for today would be integration of routine physiotherapy with advanced integration of technology is the way to the future. We have to look at it as a good opportunity. Emphasizing the role of lifestyle management and coping strategies is equally important, because without the patient's motivation and without the patient's comfort or support, a recovery is not possible. And finally, emerging trends and ongoing research in spinal neural rehabilitation is the need of the hour. Although today we say that we understand a lot of things, as Sir rightly said some time back, we all are dealing with the limited finite knowledge that we have gained, assuming and understanding that what happens is very infinite. So upgradation of ourselves into each and every domain is really an important step. So with this, I thank all of you once again for your patient hearing, and if we have any queries or any questions, thank you so much.
Dr. Shimpi, appreciate your lucid narration and acknowledge your academic excellence. In fact, this is my request. Please share the Shimpi's prone test.
Sure, sir.
And according to you, it has an 80% of accuracy. So what are the 20% remaining fallacies? This is one. Second is, as a physiotherapist, how do you differentiate between pyrepharis syndrome and the genuine sciatic pain in case some orthopedic surgeon like us misses the pyrepharis syndromes? And what do you suggest are the specific sciatic sketches in conjoined discs?
So thank you so much for your kind comments, sir. Related to Shimpi's test, I will share it. It is available on PubMed. So I will just share the link for everyone. The cases that they were not working, so we primarily had a very small sample size when we did so, and it was 70 something, where the patient had to be understood first, diagnosed as a case of back pain versus non-back pain. So sometimes the elderly population, because we have given limiting the sample size, what we found out was that in the elderly people somewhere beyond 50, this test is not working very well because the limitation of movement of the sacroiliac joint by itself. So that was one. Second thing was most of the clinical tests which are used or which are practiced in the clinical domain are based on their ability to provoke pain. Movement-based tests are not very accurate, and that's why most of the tests are suggested as a battery or combination of this. Fortunately, this test has a combination of both pain provocation as well as movement, but ultimately movement is a dicey domain because the sacroiliac joint hardly moves, not even like 2 or 3 degrees. So missing out on the movement part is what we found was a drawback of this particular test. This particular test was published, in fact this was published, I was invited to present this on an innovation conference, and have received the innovation award by the government of India for this particular test of sacroiliac joint also. For this, your second question about the demarcation of the neural tissue or the sciatic test also. So whenever we are talking of any sciatic SLR test or any other form of test, so these are all neurodynamic tests. So actually I was going to talk a bit on the neurodynamics in this particular domain. So we have the neural tissue where we have the endoneurium, epineurium, perineurium, and the entire factor is based on movement of segment and movement of every layer on each other. So there are tests based on studies by authors like Butler and Michael Shacklock, who has proposed that most of the pain, like for example when we talk of patient as a tingling radiating pain, so they propose that it is not a nerve injury, it is a neural tissue dysfunction, because nerve injury will cause motor and sensory damage. Whereas neural tissue dysfunction presents with that altered, that is altered in the sensory outcomes. So like we have the lower limb, we have the SLR test or the Bowstring test. So similarly there are neurodynamic tests in the upper limb also. And when we mobilize these segments on each other, so there are like for example in SLR, we talk of taking the leg to a particular degree, doing our maneuvers, like, and then we say that the test is positive. What these authors suggest that if you start moving the neural tissue, creating a play, the way we have articular joint play, similarly play means there will be movement of endoneurium, perineurium, epineurium, that helps gradually in reduction of the symptoms and finally taking them to the movement of stretch. So from sciatic pain or sciatica, which we commonly get to see, we treat it as a neural tissue dysfunction, going from gradually level 1, that is creating a neural play, to single-ended tensioner, that is going the joint to one particular point of stretch and mobilizing the neural tissue, to double-ended stretches, that is proximal joint complete stretch, distal joint complete stretch, and then create the neural tissue elongation. So that is how most of our patients who we have been presenting with tingling or radiating pain have shown reduction in symptoms. But of course, as I said, this is in conjunction and this is in discussion with our orthopedic team or spine team, because when the patient has to come to us, generally a lot of factors are ruled out. That there is no other abnormality, there is no other structural issues or so, and that is being clearance is given by our orthopedic team and spine team, and then the patient is referred to physio. So we have a very good communication system, and fortunately that's how things work out very nice for all of us.
So functional electrical stimulation for three scenarios: someone who is having acute radiculopathy with say a shoulder weakness or a ankle dorsiflexion weakness, versus someone who has say cord compression and having weakness, and someone who is spinal cord injured and many say weeks after the injury. Which one is it the most beneficial, or which will be most prudent to use the electrical stimulation modalities?
For what? What will be the expected
For
outcome?
the weakness, for say the
In
weakness.
weakness, then NMES is better to be used, neuromuscular electrical stimulation, because that will take care of, it's like a typical earlier.
But
vestibular
which
factor.
of these three will it be most pertinent? For radiculopathy, for myelopathy, or
No,
for
it
cord
will
injury?
help in strengthening to see, like even in spinal cord injury, it is not a lower motor neuron lesion per se. So primarily speaking, there is no affection of the weakness per se. It is just the human lesion that we are primarily seeing. So issue would be indication, whether it is really indicated and in what domains, because prolonged with disuse, the patient will start showing gradual amount of weakness like any of us. So for maintenance or patency of the particular neuromuscular junction, fair enough. FES, or functional electrical stimulation, is mainly used to train a person along with a functional task or activity. The machine is in a particular way that it will synchronize the movement. For example, it will stimulate my extensors of the wrist and flexors of the fingers in a way that I can be trained to hold a glass of water and release it. So that is in a different domain. Whereas NMES is like the way we are using, maybe earlier we were using interrupted galvanic or Faraday current. Now it is used in the clinical domain for better outcomes. So application is different, but yes, FES, no harm as long as you are giving functional task and training to a patient.
And sir, nowadays they talk about shockwave therapy, the one you showed, the laser therapy. Which are the best and which are better?
So best is the healthcare provider. These are all things that will help us. So how you make the choice in a particular condition? For example, indicated आहे की नाही आहे. For example, let's say laser आपण म्हटलं की extracorporeal shockwave म्हटलं, ultrasound म्हटलं, low impact laser जरी म्हटलं, ultimately they will cause simple things that they will cause enhancement of tissue healing, local level irradiation, increase in vascularity, washing away of metabolites, sometimes blockage of pain transmission. So pain pathway आहे, which Benzacal was describe केलेलं होतं, त्यानुसार blockage of the pain transmission also. So many of the modalities will work in an efficient manner. It is the therapist who uses them sensibly. कारण ब्लाइंडली तुम्ही काही वापरलं त्याच्या ह्याच्यात तर इट विल नॉट गिव्ह एनी आउटकम्स. सो अँड सेकंड थिंग इज दॅट इज नॉट द ट्रीटमेंट. मोस्ट ऑफ द टाइम्स हा पेशंट्स विल की हे मशीन लावलं हे ट्रीटमेंट दिलं की संपलं, तसं नाहीये. I have seen cases where maybe the therapist has been applying some stimulation to the patient आणि दुसऱ्या बरोबर गप्पा मारत बसले. तसं नाही. You have to discuss, you have to talk. Patient has to understand what is going. Communication पाहिजे. You are a part of the same team. They have to also understand that what is being done for me. नाहीतर त्यांना वाटतं इकडे घ्या, करंट घ्या आणि then it will work. नाही, it does not happen that way. So converse to the belief that the modalities are important. It's the therapist or the healthcare provider which is important. These are all adjuncts. They will help us get better provided the choice is made scientifically with evidences and with rationalization.
Sir, a lot of chiropractors nowadays, so role of it.
I will get taking you to a very sensitive area. Chiropractic is being practiced in our country also. As a physiotherapist, the belief is functional training realigning with the structural components. Chiropractors believe that structural alignments will lead to functional benefit. So they do a lot of spinal manipulations, bone manipulations, realignment, resetting and everything. But I would again say, because for example, as an orthopedic surgeon, you are trained to understand the structural factors of the joint, of the body. You will understand the structural parameters better, what is right, what is wrong. As a physiotherapist, I am trained for functional parameters. So I would not venture unnecessarily into your territory where I am not trained. So even diagnosis, I will not sit and make the diagnosis that you are a very good with. I will look at the functional diagnosis, means what is the ability of the patient to move, to do a particular task and activity, to do a particular function or training. That is my area of treatment, and that's why I started with ICF. International Classification of Functioning. I did not go into ICD, which most of you do, International Classification of Diseases. So that is a different area for us now.
Apurv, your session was the last session, but you played like MS Dhoni. You finished everyone,
Yes.
and you are.
Thank you so much.
Discussion was for your session. बाकी कोणालाही काही इंटरेस्ट नाही तू काय म्हणतो ते जास्त महत्त्वाचं.